At the point in the day where we're wrapping up, and to be wrapping up on patient engagement in the middle of Silicon Valley, thinking about sort of the high-tech possibilities of getting to patients through media and wireless. Certainly in lots of the conversations so far we've been hearing about patient education and about patient engagement, so I think that this is going to tie in very nicely. Our four panelists each have about 5 minutes of material they want to share with you. It will give us a look from sort of expertise that ranges from those who worked in government, foundations, academia, sort of community grassroots. So I think we have a nice sort of circle of expertise to draw from. And we'll be looking at this sort of quality leverage point of the sort of citizen, the patient, the person, their family, and how to engage. So we're going to start with Richard Figueroa, Fig, I understand, talking to us about Help Happens Here, the Disparities campaign. Looks like we have that up, so Fig, here, you have the microphone?
Okay.
Yeah.
So we're going to video, you'll just click on the slide itself. Maybe it's just give me a minute before you start so I can go volume. Okay. Richard Figueroa, everybody calls me Fig. I work for the California Endowment, the largest health foundation in the state. I think the folks that are up here were kind of queued up perfectly. While we do spend a lot of time, in fact, I've even offered to fund this year large-scale Medicaid health home pilots under the Affordable Care Act, which really do focus on a broad array of clinicians as well as community health workers, promotoras, kind of taking things back into the community, back into people's homes. What we really spend a lot of our time on is way upstream. We're upstreamists. We're not comprehensivists or partialists, whatever people are calling downstream folks these days, but we're way upstream. And so what we're trying to do is engage on a very large-scale basis our communities in really primary prevention. So that's kind of what Help Happens Here is about. So again, it's a campaign to change thinking and doing about what health happens. And this is kind of a little quick video that kind of captures in a nutshell kind of what we're about and help that kind of thing.
Did you know a park can prevent heart disease? A grocery store can stop diabetes. Did you know how long you live depends on where you live? Children born in neighborhoods with safe parks, fresh produce, and clean drinking water can live up to 20 years longer than those born in places without them. We can do better. We have the power to give every child a longer, healthier life, to build a stronger California. We can change the places where we live, work, and play. Because health doesn't only happen in a doctor's office. Health happens here.
I say all right now, but that's my really poor attempt at a Stanford joke. Especially because I'm a Bruin. I think I went away here. So the idea of Help Happens Here was born from public health. The idea actually happened originated here in the Bay Area with a lot of work done about how your zip code is more important than your genetic code in terms of health status. And so we're running these ads kind of all over the state to remind people that where you live really does matter. We kind of reject the notion that it's nature or nurture, because we know the environment definitely happens where you are. So again, we're trying to change the thinking. We're also trying to change the doing. The conventional notion is that your health mostly shaped by what happens in doctor's offices and the good and bad choices made by individuals. We're kind of definitely broadening that to a whole different notion where you have personal community engagement and creating health supportive conditions where people live, work, and play. We also want to change the doers in the system. Again, doctors, hospitals, insurance companies with traditional health resources, but also want to look at health departments, neighborhoods, youth, community-based organizations, schools, land use, transportation, outreach workers, public officials, all working together, also health resources. So this is our visual identity. Health Happens Here. You probably have seen this in some communities. We have 14 specific communities we're spending about $1 billion in over the next 10 years around the state to kind of change this, what we all know as the social determinants of health, which are driven by all the kind of things that we're talking about. Our focus areas are in schools, neighborhoods, And with prevention, the with prevention part is the part I most work at. It's mostly Obamacare. It's enrolling people, but also getting people to understand the broader notion of community health. Again, identifying issues or opportunities for preventive health and community wellness. And then again, our primary goal is to connect Californians with prevention-centered health with a focus on lower-income populations and places. This is kind of an example of how we deal with things in the workplace. We had Dr. Ross come to Sacramento to work with state employees who don't have the best health profile among different groups, and to kind of help work on a government or state-sponsored wellness program. Second area is schools. Again, pivotal role that schools play in social and emotional health of children. This was mentioned earlier. How do we get more healthy food, physical activity, better school discipline, policies in our schools, again, with the emphasis or notion of better nutrition and diet leading to better prevention. We have multiple kind of campaigns with sports teams and different folks to get children more activated in school health and wellness. The third is neighborhood. We try to have a big, broader conversation about land use, focus on community safety and economic opportunity. Again, you kind of got a little reference to that earlier about we help build grocery stores in urban environments. We have a large fresh work fund. We're trying to use our, the money that we have in program-related investments and mission-related investments to improve the community health in lower income areas and again provide safer places to walk, run, and play. This is an example. First Lady was out talking about the Fresh Works Fund, where we are building supermarkets to make fresh food and produce available in lower-income communities and try to get involved in zoning activities to reduce the incidence of liquor stores and fast food restaurants in urban areas. And join us. We're very actively engaged. We're looking for community partners. Again, many of you may have heard the campaign, and if you don't, probably don't frequent the same airports where we place our big ads to make sure legislators always see this kind of stuff. Thank you, folks.
Take questions as a group afterwards, but thank you, Fig. That's really interesting. I think that we may want to sort of talk a little bit about the link up between the sort of healthcare delivery system and activities like what you're leading based on the last panel's discussion, if we have a chance. Next up is David Lindeman, who is the Director of Healthcare at UC Berkeley's Center for Information Technology Research in the Interest of Society, CITRIS. And he'll be talking to us about wireless solutions for stroke prevention.
Thank you, Kathryn, and thank you for staying with us till the end of the day. What I'd like to also do is, as we switch into some of these specific opportunities to look at the prevention side of this equation, what we've heard today, is also pick up on what our last panel said. It really does speak to, tee us up, as Fig said, perfectly in terms of where technology can make a play early in this space. What we've done at CITRIS is focus, we're a multi-campus organization, UC Berkeley, UC Davis, UC Merced, and UC Santa Cruz, working at a number of specific issues, particularly around sensors, telehealth, and specific apps to work on a number of different healthcare issues. I also at this time direct the Center for Technology and Aging, which is part of Public Health Institute and CITRIS here in Northern California. And we've been working on a number of different demonstrations. We've done foundation-sponsored pilots to look at ways we can look at the healthcare system, do changes to address population health through technology-enabled solutions. So very quickly, if I can get this to move forward. Of course, this is technology. Of course. It's not been the first time that technology has beat me at the. Thank you. There we go. We have looked at a number of different areas in terms of stroke prevention technologies. In our case, it's primarily been around technologies that help in monitoring stroke risk factors and early detection of stroke. In terms of the specific risk factors, we're seeing some wonderful innovations that are moving in this space. We heard about smoking, exercise, nutrition, etc. being key issues. And that's where we're seeing a great deal of emphasis around not only the country, but examples from around the world in terms of new innovative approaches. key areas that we've seen focusing in this regard are remote patient monitoring, telehealth solutions. We've been looking at a number of different mobile health and apps that have been developed in this space. And now, specifically from quantified self movement, a number of different wearable sensors that are helping significantly in this regard. And you put that together with big data and big data analytics that are behind it, and we're moving into a very strong position of self-actualization in this space. I'd like to commend to you, though, a key issue around these technologies is not the technologies themselves. They're basically there to support, assist, they're a tool. But what I do think is critical, we have one of the best experts in the country here at Stanford, B.J. Fogg, who has been really instrumental in helping us look at how behavioral change has to be done, and particularly in relationship to technologies. I'll just mention two quick examples of types of programs that we've seen that have been very successful to date, have been published in a number of different settings, and they do deal with areas around diabetes prevention, do deal with CHF, et cetera, that are involved in this area. A specific one is a program that was developed at Sharp and working with New England Health Institute, NEHI, over in Boston. Worked on different health coaching models with care coordinators that are tied together through mHealth technology to provide guidance, education, et cetera, to individuals, and particularly those who are in very at-risk and hard-to-reach areas. A similar one is Care for Life, a program that we worked with down in San Diego, actually in Kevin's area, with Family Health Center of San Diego, a very large community health center, to test out an SMS text messaging program, which had a very successful rate, both with monolingual Spanish-speaking individuals as well as with a broader community health population. Again, two-way interactive programs. It also engages with a personal web portal. And we're seeing these being created right and left, not only in this case around diabetes, but smoking cessation, et cetera. Very promising, and particularly as we see the movement into more wireless solutions and advances beyond text messaging becoming very accessible to the broader population. Since we were tight on time, I'll just move on to say that we're putting together a number of toolkits around these spaces. We've looked at this not only from an aging perspective, but a complex chronic disease perspective. And this is clearly from the prevention side. We're just at the beginning of this area. And I'll, at this point, turn it over to my colleague. Thank you, Kathryn.
Keeping us moving, the end here. But with very interesting content. Thank you. You did give us a nice taste of what's coming and what's already there. Our next speaker is Liz Helms. She's president and CEO of the California Chronic Care Coalition, and she's coordinator of the San Diego Right Care Initiative. Be there. She's going to be sharing the patient perspective with us. So here we are, right in the center of what this is all about.
Thank you. Thank you very much. I'm so excited to be here today. And the coalition has been part of the Right Care Initiative, came on as a partner early on when I met Hattie. And once you meet Hattie, your life has changed forever. So my life hasn't been changed forever, but much to the better. And we have spent countless hours, days talking on the phone, driving home from meetings to keep ourselves awake because we've spent 18 hours on the road trying to go out to the community and really make a difference. And we're so proud of the work that's been done with what's happened in San Diego as the model for the state in bringing together the clinical team of experts and passion and guidance led by Anthony DeMaria, who's the editor-in-chief of the Journal of American College of Cardiology, who is superb. And was sorry he couldn't be here today. He really wanted to be here today, with Dr. Duddle and our new executive director, Kitty Bailey, and Scott Flynn, and just an amazing team of people. So what I want to talk to you, and started a lot by Jerry Penso, who we're so happy to see here today. We haven't seen for a while. So I want to kind of bring everything together today of why we're here. We're here because we're talking about the patient, and we're talking about patient-centered care. So I'm going to just quickly run through a couple of concepts that we've done with our Be There campaign, and then I'm going to let a couple of patients talk for themselves. It's very compelling stories. And what you're going to see is some of the concepts. These are videos, and talk about going outside of your comfort zone. I did 2 videos in my presentation, but I think that they're so compelling and so interesting in tying this whole thing up together that I went ahead and did them, and hopefully they're going to all work. And so let me go through a few of the concepts. So these are some of our concepts, someone graduating from high school to be there to see your daughter or your son graduate from high school or college or whatever. Seeing your daughter within the Latino community and very diverse communities, African American communities, seeing your Sweet 16. This was actually Hattie's story, which is very compelling and always touches my heart. And so the campaign was put together to bring that emotional tug into patient activation. That if we're not going to be there for ourselves, who will we be there for? Will we be there for our family? Will we be there for our friends? Will we be there for whatever life important moments are going to be there? And so what I want to do now is take you into Jose's life. And this is A Million Hearts tie-in with what some of the concepts that we've done in Be There.
My name is Jose, I'm 55 years old. I had a stroke about 9 years ago. In my family, the strokes occurred mostly on my father's side. My father had a stroke, his sister had a stroke, and then I had a stroke. All within weeks of each other. I just started feeling like somebody was going around my body, turning systems off. I had a tingling sensation in my leg, and it couldn't move anymore. I had a tingling sensation on my arm, and all of a sudden my arm couldn't move anymore. And then I just passed out. Over the next couple of days, I really couldn't talk much at all. I couldn't move either arm, I couldn't move either leg. Eventually I got control of one side of my body, my left side, but I still wasn't able to talk much at all. When I transitioned to my house, I was still in a wheelchair. Myself, my wife, my children, my mother, my friends, we all chipped in and developed a plan where I would be receiving therapy one way or the other for about 5 or 6 hours a day. And that was when I started to see faster results. I was gradually able to learn how to walk again. My arms started being able to move again. I could start to speak a little more fluently. Dancing with my wife. Going to my daughter's graduation. Sharing with my friends again. Me.
Hold your thought.
My name is Andrea and I'm 42. The day of my heart attack, I was on my way to work. I woke up in the morning feeling nauseated and tired. I had heartburn. I thought it was all my morning sickness from being pregnant. As my day progressed, my symptoms got worse. My jaw tightened. My left arm went limp. I had extreme burning in my chest. By the time I'd gotten to My name is Anne. I woke up in the morning feeling nauseated and tired. I had heartburn. I thought it was all my morning sickness from being pregnant. As my day progressed, my symptoms got worse. My jaw tightened. My left arm went limp. I had extreme burning in my chest. By the time I'd gotten to the urgent care center, it had been 6.5 hours from the onset of the symptoms. And I was, at that point, so critical, I had to be airlifted to a local hospital. They were counting my life in minutes. I got to the hospital, they had to do emergency surgery. They placed a stent in my artery that was blocked. I spent 10 days in the coronary care intensive care unit, and during that time, I lost a baby as well. I did not realize that I had all the classic signs simply because I had honestly never taken the time to learn what those signs were or to learn about women and the risks for heart disease. A words of wisdom for anyone would be to educate yourself about your risks for heart attacks and heart disease. Spending time with my family, enjoying my friends, playing with my dogs. Me.
Okay, oh boy, that took, woo.
Great.
Wow. We can do better. Are these preventable? We had Andrea, she didn't even know what it meant, what her numbers were. She didn't know what it was to have high blood pressure. She didn't know, but we can together do better than this. And that's why we're here. We're here for the patient. We're here for our families. We're here for your families. What can you do about it to make that change? You're all talking about it. I'm so proud of you. I'm so proud to be a patient advocate this time, not in the 90s when all we did was fight. Now we're together, working together, and we're making progress, and it's awesome, and it's enlightening and inspiring. So we want you to join us in what we're doing to make this better. So we came up with our own ACE. You're our ACE of hearts. Activate, communicate, and engage. Be there. Be our ACE of hearts, and we'll be your ACE of hearts. Impact. San Diego's changing lives. Join us for yourself, for your patients, for your families, for the community. We can make this happen. We are making this happen. And it's so exciting to be a part of this as we move forward. So thank you, Right Care Initiative. Thank you, Hattie. Thank you, Dean Shortell, for all the work and energy that you've put into making this happen. And thank you all for being here to talk about this and have this conversation.
To get inspired. Wonderful, thank you. Our last speaker on this panel is Kevin Patrick, who's Professor of Family and Preventive Medicine at UC San Diego. So we're getting the southern part of the state well covered right now. He's also editor-in-chief of the American Journal of Preventive Medicine and director of Qualcomm's Institute's Center for Wireless and Population Health Systems. That's the technology angle. And he's going to be talking about engaging the whole health team through mobile and home technologies. So we're going to link right into the delivery system now, I believe.
Thank you, appreciate it. It's really hard to follow those, and just the level of enthusiasm. Why did I end up having class? And right between you and the reception, so that's also a problem. Delighted to be here, and I am a partner in the San Diego group. I've been a recent addition to it, and it's really been exciting to see focus on this. So this is where I work, the Qualcomm Institute, one of the California Institute for Science and Technology, like CITRIS, where David is located up at Berkeley. And we have a laboratory there that focuses on a variety of things. We focus primarily on behavioral interventions and use technologies in this area, so a variety of things funded by a variety of different sources. And this is highly interdisciplinary work, so a lot of the work that I think is going to move us forward is going to be this collaborative work that we're doing with engineers. And I've talked about this, people have heard me talk about this need to bridge, because engineering solutions are things that can actually make a broad impact and be part of the system of the future. So our research, and this is going to echo a little bit of what David talked about, is what we focus on. We focus on health and behavioral and social issues, we focus on technologies, and we focus on design. This is what BJ Fogg talks about a lot. If people don't use technologies, they're not going to work. And so design is really critical. And the sweet spot is in the overlapping areas of this when we think about what we have to work on. So I'm also going to echo what Fig said. We're a Robert Johnson Foundation funded project. Our research is informed by an ecological framework. I've worked with Jim Salas and the Active Living Research Initiative since its inception. Health happens where we live, work, learn, and play. And this is really a critical aspect of this. So I couldn't second that more. But how do we understand health? I mean, if in fact that's the case, how are we looking at health data and health-related issues? Well, typically it's clinical, randomized controlled trials, or it's biomarkers, or it's electronic medical records, or it's periodic public health surveillance systems of some sort, which don't necessarily reflect where we live, work, learn, and play. These are different forms of data that might be orthogonal to where we need to have this. And then how do we intervene? And again, not this group, but the way we think about this is, long waiting lines in rooms to go see the doctor, you get your prescription, and then you stand in line again to get your medication. Not a pleasant experience for most of us, and we can all relate to this. Well, the times are changing. They're changing remarkably, and it really is worth restating what David said. This whole tsunami of activities that's happening out there is changing. We're tracking our health data enormously. The Pew Foundation did a study earlier this year. 20% of Americans use some form of technology, some sort of weight scale, an app, device, or whatever, to track a health-related parameter. 69% of adults in this country track it in one form or another, stickies on the refrigerator. Right? So people are doing this. They're interested in health already, so they do this. And there is this movement, the quantified self movement. It's a growing movement, and it's a signal that if in fact people are so passionate, they get in meetings and they share the stories about quantifying every little bit of stuff about themselves and whatnot. You can think that that's fringe and wacko, but how do things start in this country? How did the anti-tobacco movement start? And how did we get to less than 10% in California? It's because the fringers and wackos said, hey, we're not going to put up with this. And then people are sharing health-related information. Increasingly more and more people are willing to share their data and open their data up to other people. They're not so concerned about the privacy potentially as what other people might learn and how they can share it. So patients like me is a perfect example of this. And then increasingly there is digital data tracked about every aspect of our lives. Now we all know about the Snowden thing and whatnot, but we're a room full of people who are very interested in health. Lots of data that are captured on us and about us can be used to make inferences about health. And so this whole increasingly diverse and expanding set of ecosystems is not being built by us. The technological and financial imperative is all out there by other people. The two largest segments of the economy in the United States are the healthcare economy and the information technology economy. These economies are merging, and there's a huge push to make them merge. And here, I'm saying this, Colston, Newcastle, and Palo Alto, it's sort of like, I don't need to tell you folks this. But we do a little bit of it down in San Diego. So we've just started this project, and I'm really excited about this project. This is called Health Data Exploration Project, where we're really trying to find where these forms of data might be outside of the traditional forms of healthcare and leverage them for purposes of improving individual and population health. So this is a new initiative funded by the Robert Johnson Foundation. We're interviewing and addressing 3 primary stakeholder groups: the individuals who capture and collect the data about themselves, the researchers that might be interested in doing something with those data to improve health, including clinical researchers who want to bring those data into the mix of the very subject of this entire day's meeting, and then the companies that capture these data. The companies, these enormous companies sometimes, the Googles, the Facebooks, the Twitters, but the smaller companies, the startups that today might be small and could get bigger tomorrow or whatever, those companies aren't necessarily interested in public health or individual health. They're interested in selling a device, selling an app. And if they want to use the data, they might want to monetize the data for their own purposes. How do we get them to think about helping us do what we want to do? And so there's a real, we call this project personal data for the public good, and we're very interested in making that happen. So let's bring this back around to the subject of this meeting, because Liz and Hattie wanted me to make sure that I commented on this notion of just simple wireless blood pressure monitoring. We built this into our proposal for the CMMI grant, which we hope we might get, but this is a technology that's there and that is proven. And their JAMA article this last summer wasn't my study, but I'm proud to sort of feature this because the commentary that was written on this was written by our associate editor for practice, Bev Green, who's from Group Health Cooperative up in Seattle. But this notion of just a home blood pressure monitor making a difference at a year and then 6 months follow-up, just simply giving this fully half again more people with this particular treatment got better with respect to managed hypertension than who didn't have it. And so we're talking about the 700,000 people reached them. What if every one of those had a home blood pressure monitor, which is not all that expensive? And what if that monitor was integrated into some form of a system to help them? So this actually is a step that can be taken now. It's a straightforward thing. It's very aligned with a lot of the work that many of us are doing. We're building infrastructures and building the evaluation platforms that can help embed these things there. All that needs to happen is that people like you in healthcare settings need to ask to make this happen. And as they point out here, the insurers should provide for these, clinicians should be reimbursed for the care that's provided by these, and home blood pressure measurement should be included within quality metrics, which is a lot of what has been discussed in this meeting. So, moral of the story, these technologies are there, they're proven, they should be used, and we're trying to get them used in San Diego better, and Jim Doodle has been leading that, and Kaiser and others. So that's my story.